TBI, and then afterwards he'll also be giving a special lecture on hypothermia for ICP.
Mr. Chairman, is this turned on? Yes. You can hear me, perfect. So Mr. Chair, thank you for that generous introduction, and thank you to the organising committee for inviting me to this meeting and to your partner city. So
we need the mic on. You got to turn the
hear
switch on.
With the projector. Is that it? Okay. That's probably about 2 minutes. Okay, I guess you can hear me now. Could we have my first slide, please? Okay, so my topic of my lecture today is neurocritical care of traumatic brain injury. My plan is to try and get you to challenge some of the dogma, the perceived wisdom, and think about where we should potentially be heading in the future. Okay, that's the second slide. Okay, so that's the purpose. What I don't want to do is cause complete confusion and mayhem in the ICU. I think currently most of us feel confident when we do our rounds, when the nurse and the junior and the fellows on the unit ask us, can you write orders for this head injured patient? Well, we all tend to comply, I think, with what we consider to be Brain Trauma Foundation guidelines. So we're all pretty confident with CPG of 60, ICP less than 20, blood gas targets, you name it. Everybody likes targets, and these days the quality marker in critical care in the UK is that the attending writes twice in 24 hours in the notes. So you have to think of something to write, so it's very useful to write these targets. I think it's time to challenge some of the dogma. So my disclosure is that I'm part funded by the NIHR in the UK. Basically, that's the Department of Health for the UK government. And what I have to tell you is that the views that I'm telling you now are my own and not theirs. Another key thing to remember during this talk is when I talk about an absence of evidence, that is not the same as being an evidence for absence of effectiveness. So I think part of the challenge that we face, and Randy talked about this morning, is this absence of evidence. It may well be what we're currently doing is the right thing to do, and I'll show you some not very good quality evidence to suggest that's the case. But we need to get better evidence. So neurocritical care for a head injured patient, where did it all start? Well, I think when I look back, and I wasn't around, or I wasn't working clinically when this was developed. This is the Glasgow Coma Scale. I think a couple of years ago it had its 40th birthday, so the Glasgow Coma Scale has been around for 40 years. And it allowed us to communicate about the disability of a patient following traumatic brain injury. And for analytical purposes, statistical analysis, the Glasgow Coma score was added to the scale. Now, many of the problems that you'll hear about the Glasgow Coma scale are actually because of this numeric score. But it did allow us to start doing research on traumatic brain injury. And it's coincident with the development of the Glasgow Coma scale, identification of similar cohorts of head injured patients, triggered the development of neurocritical care, admission to a unit where invasive mechanical ventilation could be performed, prevention of hypoxia, recognition and treatment of hypotension. So neurocritical care developed pretty much following the development of the Glasgow Coma scale. This led to single centre, an occasional multi-centre, but a small number, probably fairly poor quality by modern standards, trials to look at the effectiveness of some of the things that we do for these patients. But I believe actually the diversion from proper randomised controlled trials in neurocritical care resulted from in the early 1990s, where Big Pharma started to do neuroprotection studies. These were very well funded, brought quite a lot of investment into neurocritical care. Unfortunately, sadly, they were all negative, but it deflected attention from some of the more basic research that we could have been doing at that time. So in the UK, we're told that the best single source of evidence about effectiveness of clinical interventions is the Cochrane collaboration. Now, these are very rigorous, systematic reviews. They only select specific sorts of trials, patient-orientated endpoints in them, adequacy of completeness of follow-up, and only trials with as little bias as could be possibly accepted for the intervention being studied. The problem is, and I don't know if any of you have used Cochrane, at the end of almost all the systematic reviews it says, there's a paragraph that reads almost identically, that because of the small numbers of patients recruited, it's difficult to be confident about the effectiveness or otherwise of intervention under investigation. So in terms of developing how do you manage a patient, Cochrane systematic reviews are not particularly helpful. Very helpful if you're wanting to start a clinical trial and get funding because they are so rigorous, but not helpful for clinical management. I think the Brain Trauma Foundation is the exact opposite. I think, and Randy mentioned that this morning, I think certainly amongst clinicians there's definitely pressure and the need to produce sort of management algorithms rather than assessing the quality of the evidence that was out there. So if you go online, and I'm delighted to hear they're going to be updated this year at some point, you can download PDFs for almost every aspect and every cause of traumatic brain injury from the Brain Trauma Foundation website. And as we heard this morning, it's not based on a huge amount of evidence. So let's stop and think, what do we know? Well, we know that there are three key components to the traumatic brain injury evolution. The primary injury, well, public health measures are there to try and reduce the number and severity of head injury, but for neurocritical care specialists, there's very little we can do about it. Secondary injury processes, secondary injury 2 at the bottom, are the sort of cellular mechanisms that are thought to be injurious to the brain and are triggered by that primary impact. As it has been said before, the brain is filled with seeds of its own destruction. To date, we do not have a therapeutic that can beneficially modulate these secondary injury cascades, the cellular cascades. So we're left with the sort of so-called secondary insults, hypoxia, hypotension, raised intracranial pressure, etc. And that's where neurocritical care's focus is. Traumatic brain injury is a heterogeneous condition, and whether you're a clinician looking after a patient following traumatic brain injury or a researcher trying to study them, that's one of the major challenges that we face. So this is a simple slide with 6 possible brain injuries that could cause your patient to be GCS3. For example, if you look at subdural hematoma and contusional head injury, a lot of intraaxial hemorrhage, and if you look in the laboratory, a huge amount of inflammation involved there. The exact opposite is true of diffuse axonal injury. So quite varied. So to go back to the guidelines, the most recent ones are 2007, and I wrote on when I was preparing my talk, where is the update? Well, we've heard the update is coming, and probably about time too. But if you look at this, I think it's something like 12 or 14 area domains where advice or treatment options are considered. Prophylactic hyperventilation and steroids are prepared. There's class 1 randomized controlled trial evidence to suggest that they're not beneficial or might be harmful. All of the rest, these are things that you were asked on your daily rounds, and for which there is not very strong evidence. So, the causes of these secondary injury processes that you may be involved with managing in the intensive care unit: hypoxia, hypotension, hypocarbia. Well, we identified many of these during an MRC-funded project where I worked with the late Douglas Miller. The thresholds, however, for individual patients is unclear because of the quality of the data and the way we analysed it using logistic regression. Now we're going to hear about the future of intracranial pressure monitoring. It's often considered the cornerstone of traumatic brain injury management. And unofficially, Professor Ian Roberts, who ran the 10,000 patient crash trial, which really is a tremendous achievement to recruit so many traumatic brain injury patients. Well, Ian told me that they considered that neurological ICUs that monitor intracranial pressure, they considered them to be high quality ICUs. So they used the the presence of ICP monitoring in a neuro-ICU as a quality marker. So sort of indirect evidence that is associated with good practice. Well, here's two publications from Ian Roberts, and unfortunately you may not be able to read them from the back, but it's a very simple message. So in 1998, not shortly after the publication of the first Brain Trauma Foundation guidelines, Ian Roberts from the Cochrane Injuries Group published a summary systematic review in JNNPs back in 1998, showing the absence of evidence for effectiveness for most of the things that we were doing in neuro-ICU. Interestingly, the intervention that showed most promise, there were more trials on it, and a signal favouring the intervention was steroids, and we know how that ended. So in 2008, Ian Roberts had believed that the publication in 98 should have been a call to arms for the neurocritical care community to go out and do trials and get some evidence for these interventions. So he wrote a paper in BMJ, the British Medical Journal, under the heading of uncertainties, suggesting that there still was no more evidence for things that we were doing. So how are we going to move forward from this? Well, I think this simple logistic regression, looking at all head injury patients and the physiological derangements that they may or may not have suffered, had led to this idea that we're looking for an intervention that one size will fit all, and that's just not going to happen. So back in the day, I did some collaboration with an artificial intelligence expert looking at machine learning. And these guys knew nothing about head injury, but what they came up with is this thing called a regression tree. And basically, if you ran the regression tree until it was finished, every single patient would wind up in a category on its own, on their own, and that's because we're all individuals. So you can't do that because it's just not very helpful. So you can get the machine learning program to truncate after 5 or 6 nodes. But it identifies subgroups of patients in whom there were interesting findings. For example, here, if you look up at the top of this regression tree, any episode of profound hypertension is associated or led almost 100% to poor outcome. Lower down, the nodes are less discriminatory, but identify subgroups. So possibly this sort of machine learning might allow us to identify thresholds and interventions for subgroups of head injury patients in a way that we haven't done before. But at least it needs big data. So to finish up with, about 5 or 6 years ago, the Scottish something or other guideline network, I should know this one, I was involved in it. It's called SIGN anyway, but it's our evidence-based guidance that we use for clinical practice. Now that we're trying to become an independent country, we have to duplicate all the efforts of NICE in England. And nonetheless, our coordinator for SIGN decided that traumatic brain injury was an area that deserved particular Scottish guidelines. And not particularly morale-boosting question that I was given, or my group was given to answer, is there any evidence for neurointensive care as an entity or evidence for expertise that might be housed within such an establishment? So basically that's what I do for a living, but yet I had to go out and try and find some evidence for what I was up to. So this is historic data, and because Scotland and England and the UK generally is somewhat resource-starved, we spend much less on a health service than most other developed countries, that the suboptimal management of head injury led to a number of opportunities. Now these data come from something called the Trauma Audit Research Network, TARN, and they audit every single trauma patient that comes through an emergency department front door. So the data set that were analysed for this study were almost 52,000, of which almost 5,000 patients had diagnostic category of head injury. Now, we looked at them for sort of age, gender, and injury severity matching. And as you can see on the right-hand side, there were a number of patients who did not require operative neurosurgery and were admitted to a non-neurosurgical centre. There were similar matched patients admitted directly to a specialist centre with neurosurgery present. You can see, hopefully here, there's almost half the number of deaths in the specialist centre. Now, when the manuscript was initially submitted to the Lancet, the editor said, well, the reason for that is that the neurosurgery colleagues are actually very good at triaging patients, and that's why all these patients were left out in the non-specialist hospitals. But the data were reanalysed, and the statistician persuaded that we get adequate matching. Now, why might that be? The amount of arterial hypotension was markedly different between the non-specialist and the specialist centre. So, potentially, an explanation for that finding. Despite that publication and the general agreement in the health department that more money should be spent to admit patients directly to specialist centres, that didn't happen. And a second piece of work was performed, the risk adjustment in neurocritical care study, the RAIN study. Now, this study actually suffered somewhat from a lack of completeness of follow-up. What we wanted to see was direct transfer into specialist centre effective and, more importantly, for a cash-strapped health service in the UK, cost-effective. So what we found was, well, because of the problems we had with completeness of follow-up, there's a degree of uncertainty in the results. However, the general consensus was that the dedication of a specialist ICU was more expensive, but the sort of health economic analysis was that was a reasonable cost for additional quality of life year gains. One of the speakers earlier this morning talked about management of older patients, and certainly we admit older patients to neurointensive care, but the RAIN study suggested that there were actually no benefit from early transfer of the over 70s. So finally, just to wind up, I'd like to thank you for your attention. Remember to challenge dogma, and although maybe the guidelines aren't as evidence-based as we like, admission to a specialist centre, and almost all specialist centres will tell you that they follow these particular guidelines, the outcomes seem better. Thank you.